Can I be
Yes,
heard?
we can hear you, Doctor.
Ah, okay.
We can hear you very well. Thank you.
Ah, nice, nice. Sorry, it's these challenges of technology. So today we have an interesting topic to speak about, which is insulin. I made the decision to actually talk about this topic because it's one of the controversial aspects of treatment when it comes to treating patients who have diabetes. So kindly allow me to share my screen because I have a small presentation. I'll want to make it, I don't know if I can share.
Terry, can you try? In the meantime, let me see if I'm able to change my settings here. But of course, you'll need to go back and see if there are any people in the waiting room and admit them in. But let me, if you're not able, I'll have to hand over being the host. So you will need to check and admit a few people. Just a moment.
Yes, it tells me it's disabled that you need to.
Okay, one moment. Okay, Doc, you're good to go.
Okay. So I think you'll just be admitting for them because I won't be able to do all at the same time. Motanya?
Yeah, I can hear you. I'm not sure if I'm able, but I'll try and see if I'll text you if it's not, I'm not able to do that.
Okay. So slide. From beginning. So everyone can see my presentation. So I was just saying that I thought talking about insulin would be a great idea. And I'll mention why I thought it would be a better idea to talk about it from just a moment, from a doctor's perspective. There's a patient perspective and there's a doctor's perspective. We, as healthcare practitioners, meet a lot of resistance when it comes to trying to prescribe insulin to patients. And maybe I'll mention a few reasons why we one of the common misconception about insulin is that by the time a healthcare provider is prescribing insulin to you, you are in the end stage of your disease. That's one misconception. The second misconception is that insulin is painful. Insulin injection is not painful. And that misconception, I hope I'll be able to demystify it also again today. So just a small rundown, just to remind you, before 1926, actually, you can see the story of Marjorie the dog. This dog is what has enabled many people to be able to get that today. These are Canadian professors. What they discovered was that they tried an experiment. Before 1921, the treatment for diabetes, especially those who needed insulin, was actually to starve them as much as you can, which now with the current knowledge, you will figure out that was actually a bad decision. So they removed the pancreas of this dog, okay? Then they saw that the glucose reading from the dog had gone up. So the next thing they did is they got the pancreatic extract from the same dog and injected it back to the dog, and the sugar went down. So they quickly discovered that a pancreatic extract was the one that was responsible in controlling the glucose. So from there on, now you can see that what we've managed to do all that time is one of the first insulins was being prepared from what we call animal insulin preparations. So getting the pancreas of these animals and extracting the pancreatic extracts from this animal. You can imagine that I'm injecting you with a pancreatic extract from a pig. It works, okay? But you develop sensitivity to that because that is a molecule from a different animal. So it will lower your sugar, but you develop hypersensitivity to it. But then with the advent of technology, we were able to now isolate the human insulin. Now, isolating the human insulin was done through these DNA processes, whereby we were able to know each of the constituents that make an insulin in terms of its DNA chain. And from there on, we will be able to now give that information to some sort of bacteria called E. coli to generate the human insulin for us. How do I give that analogy? The analogy can be shared like, for example, for people who are infertile, taking a sperm from a male and an ova from a female and fusing it in a tube for it to grow and implanting it in another woman so that they give you a child who's biologically yours. So the E. coli is like the other woman. So we are giving it instructions to just remove the same copy of insulin that we have. And there is when we made what we call human insulin. And that was a game changer. You can imagine human insulin, the people who discovered it actually gave the patent out for free.
Doc,
you can imagine
Doc, just 1 minute. I'm seeing some members who are saying that they're not able to hear you. In the meantime, maybe you can check if we've got anyone in the waiting room. So can anyone respond that they're able to hear Daktari? Because on my side, I do. So
I can hear him.
Hear me?
Okay,
I can hear him.
Yeah.
I can, but he's breaking.
Or it's breaking a bit, Daktari, because I think also we are able. I'm seeing that your network is not could be an issue, but I can hear you though there's a bit of breaking. But it's fine then. You can
okay,
go on.
Just a moment. Let me try and correct that with just linking my phone with it. I think the network from Safaricom these days is just, so I'll have to go off the video.
Okay, no problem.
Just a moment.
No problem. So as Daktari checks on his internet connection, I wanted to say for anyone who might be here and is new, just I wanted to inform them that Daktari consults at the DMMC Ngara every Saturday. So you can come and get to talk to him anytime as from 9 up to around 1. So, and again, in this session, after Daktari completes the first part, everyone is allowed to ask questions. They don't have to be ideally all about insulin. You can ask any question that is related to managing diabetes. So I would recommend that if you have any questions, you can use the chat function. Alafu Daktari akimaliza the presentation, he will now go to the chat area and pick questions and answer them. So karibu everyone, and mute your mics and asanteni. So Daktari, if you can hear me, you can confirm.
Yeah, I can hear you. I think I can now be heard better.
All right, I believe so. I hear you.
Okay, fine. So after human insulin was produced, I want to give you a scenario where you can imagine the human insulin is released from the pancreas directly into circulation. So this is just anatomy. But here you've created the same human insulin and you want to give it from the skin. The conditions with which they will work is different because if you're giving it from the skin, it will take some time before it gets into the bloodstream. And that is why you'll find for human insulins, we'll tell you, inject 30 minutes before a meal. So we also wanted to go behind that. And we discovered that we can change some parts of the human insulin to make either the absorption faster or the absorption slower. Now, why is that important? Is because if you want to make the insulin absorption faster, you are aiming for that insulin to work on that food immediately and lower, so that when you eat and I give you the insulin, it lowers the glucose back to normal in a very fast way. And if I want to have you give you insulin that works slower, is because I want that insulin to work when you are in the fasted state. So those times that you're not eating, insulin also has to be released because it needs to help with the bodily functions. Now, if you discover that, then you discover that we have made changes on the human insulin to either make it work faster or slower. So we have two types of insulin. We have what we call the human insulins, and we have what we call the analog insulins. So analog insulins are the newer insulins which have less side effects and work faster or take longer to act, depending on the type of insulin, the type of mechanism of insulin that you want. This is just a presentation of what I want to say about homeostasis. Homeostasis is generally keeping a good environment for the body to work. So we are looking at a glucose level between which we know that it will not bring issues to your body. So the body has a way, it's like a thermostat. When the temperature goes up, it lowers it down. When it goes too low, it heats it back to the level. So I want you to imagine your glucose level as being controlled by a thermostat. Okay, so that is how the body handles. So for example, here, the stimulus is when you eat, the glucose goes high. The pancreas is stimulated by that glucose to release insulin. The insulin drives that glucose into the liver and into the cells, and the glucose goes back to normal. On the other hand, if you're not eating, your glucose goes too low. A hormone called glucagon stimulates the liver to release glucose to return back your glucose to the normal level. So I've given the analogy of a thermostat so that you understand why your body has to regulate the glucose to be within a good normal working range. Now, I didn't put it in this presentation, but I felt it is important for me to tell you who needs glucose and who doesn't need glucose. Okay? The patients who need glucose are those who cannot produce glucose at all. That is number one. Those are what we call the type 1 diabetes. The others who also need glucose are those who have developed a type 1 diabetes in adults, what we call LADA. So they also need insulin. The other type of patients who need glucose are pregnant women. Why? It's because during pregnancy, insulin is the best medicine for management of glucose. Though you might find there are patients who we give metformin, but that is a topic for a different day. The other people who need insulin are those who are type 2 and have come in with very high sugars. So most of the time, we check your HbA1c and it's above 9%, we will want to give you insulin just to lower that glucose to normal before we can continue with the oral medications. The other kind of patients who need insulin are also type 2, who, despite giving them oral hypoglycemic agents, which means the medications, the oral medications to control the glucose, it cannot manage to lower the glucose. Meaning, with time, your pancreas has ran out of beta cells which produce insulin. So at the end of the day, you might find you are a type 2 who was actually controlling your glucose well with glucophage. Then we went to diamicron, then we added another one. Then it reaches a point we tell you, you know what? I think you just need insulin. It's because your beta cells have been depleted. And it doesn't mean your disease has worsened. It just means that you've been depleted of your beta cells and it's time to give you insulin. Now, The other people who give insulin is in the ward. You will find that you are a type 2 diabetes. You go to the ward, you've been taking your oral medications, and in the ward, we decide to change you to insulin. It's because in the ward, insulin is a fast-acting agent. And because disease can change your condition very fast, we also want to use a drug that can be able to adapt to the situations as fast. Then when we discharge you, we find that you might actually discharge you back to your oral medication. So I hope I've tried to finalize on the issues of who needs insulin, when do they need insulin, and actually now I'm going to talk about the conditions with which we might give you insulin, especially for type 2 diabetes, because type 1 is straightforward. We will give you insulin because you do not produce any insulin. But today I will just try and actually talk more about it in type 2, because that is where there's a lot of controversy. Now, we need to know that I have shared the conditions under which a type 2 will receive insulin. So if your beta cells have been depleted so that maybe you've had diabetes for too long and you are on 3 medications and they are not controlling your sugar. 2, if you are being admitted in the ward, you will need insulin. 3, if you are newly diagnosed, okay? So you are newly diagnosed and you come up with very high sugars, we might give you insulin for a short period of time, lower your glucose back to normal, then now we can actually just continue on oral medications. Now, insulins come in many types. So I have just told you we have what we call human insulins, which is actually just a photocopy of the insulin that your body makes. And we have analog insulins, meaning we've modified some parts of the human insulin to gain some functions that we want. So between human insulins and analog insulins, we can further break them down. So we have what we call rapid-acting insulins. So rapid-acting insulins are the insulins we give to control glucose of the food that you've just eaten so that it's lowered back to normal. Remember the thermostat analogy, okay? We have rapid-acting, we have regular-acting insulin, which is the human insulin, one known as Actrapid. Then we have what we call an intermediate acting. So it sort of has a mixture. So we have NPH, which is rarely used these days. Then we have the long-acting insulins. So the long-acting insulins control your glucose when you are not feeding. So here we have things like Lantus and Levemir, okay? And in the rapid-acting, we have things like Apidra, Novorapid, and Humalog. Then we also have another type of insulins, which we have combined 2 insulins. So you'll find we've combined a short and an intermediate, meaning we want to control both your food and the period when you're not eating. So in these ones, we have combined 2 insulins to make one thing, something like called Mixtad. So which is a mixture. Mixtad is just mixture. So here we are giving you one insulin that has 2 benefits. That it can control your meal and it can also control the period when you're fasting. Then, so there we can combine and in different ratios. So you'll hear things like Mixtad 30, Mixtad 50. So it depends the ratio of the rapid and the intermediate, okay? And you'll find there are some patients who will start on Mixtad, there are patients who will start on a long-acting, there are patients who will just plainly start on a short-acting. If you recall, there may be times your doctor will ask you to take what we call a 6-point reading. So they'll tell you, record the sugar before and after each of the meals. So those are 6 readings. And they'll be able to identify where your problem is. So either your problem is in fasting or is in the postprandial glucose, meaning the glucose reading after your food. So we try and figure out where the problem is and we give the appropriate insulin to work on the problem that we are seeing. So that is why there are some patients who will start on a mixture insulin. There are patients who we might just start on a rapid insulin. There are patients who we might just start on a long-acting insulin. Now, if we go by that, then the issue becomes, for how long will you receive insulin? For type 1 is for life. For pregnancy, it's just for pregnancy and we stop. For type 2, it depends on the condition. If you come newly diagnosed and your sugar is too high, we'll give you insulin, we'll lower the glucose to normal, then now we will stop it. But if you have had a progressive disease whereby it has reached a point whereby your beta cells are not producing any insulin at all, or very minimal insulin, then we will have no choice but to give you insulin for the rest of the time. Now, the other indication that maybe I had not indicated is for type 2 diabetes, those who have developed renal complications. Now, why is that important? Is because most of these tablets that we are giving you, okay? Most of these tablets that we are giving you, they will not be eliminated from a kidney that has been injured. So because those drugs won't work well at that point, we'll just give you insulin because insulin will continue to work even with an injured kidney, okay? So that is some of the conditions that are there for us to give you insulin. Now, when we give you insulin, we always give you instruction. We tell you, measure these kind of readings that we want. Either we'll tell you, we need you to give us your fasting readings, or we need to give you, you need to give us readings after your meals, or all the readings. Remember to be compliant to that because it helps us to detect if there are any problems that we need to figure out and manage before it brings a problem. Because one of the issues with insulin is it can actually lower your glucose to go too low and it becomes a problem, okay? Or you might be giving insufficient insulin and your glucose goes too high and also that becomes a problem. So the things those instructions that we always give you, you need to take them seriously because they help us to help you, okay? Now, insulin comes in many forms. So there are those insulin that come in a vial, there are those insulin that come in a pen, and even in other countries, there are insulin that can even be given by inhalation, but it's not here, okay? And there are insulins which are given by devices. By devices, I mean, there are some devices which we call artificial pancreas that we can actually put somewhere on your body so that they continuously give you insulin when you deserve it. Now, when it comes to insulin in a vial, you'll always be given a syringe. Most of you have seen that syringe. It's usually orange in color. And it comes with a needle called a microfine needle. That microfine needle has been designed so that it actually doesn't inflict very minimal pain when you're injecting yourself. But we have now designed what we call pens, insulin pens. So these are pens which have been pre-filled with the insulin. And the advantages of these pens is actually you don't need to store them in the fridge once you open. You can actually travel with them. So they give you the convenience of moving around with them. Okay, so you don't need to titrate. It comes with something that helps you, to regulate and say, this is the amount of insulin. So you can rotate and say, I need 10. You rotate until when it's 10 and you just inject yourself. Okay. Then there are those that we call devices, which I'm not going to get into them because those ones are a bit complex for this discussion, but they are there in this country. Then there are these things about what I wanted to talk about, which is complications. Now, people ask, if you're giving me insulin, what complications can I expect? One of the common complications we expect from insulin delivery is actually hypoglycemia. So whereby your sugar falls below 4. And that is a problem because hypoglycemia puts you at risk of many issues. Cardiovascular events, which means you might get a heart attack, it increases your chance of not knowing when you're getting a heart attack or a stroke and such things. So we try to avoid hypoglycemia at all costs, okay? The other issue with insulin is because insulin is also diverting glucose into the cells. So when it's diverting glucose into the cells, you add weight. So one of the issues, again, is that you might actually add weight with insulin, okay? And it depends on the type of insulin. Not all insulins will add weight uniformly. There are those which will be having minimal addition of weight and others which will have excess admission of weight, okay? But that is just a discussion that we'll have on the forum. Now, there are some people who develop hypersensitivity. So they react to the insulin. It's not common, but it's actually there, especially with the human insulins, okay? And rarely with the analog insulins. So those are some of the common complications that you will get, okay, with insulin. So I wanted to just give you a rough overview of what insulin is, what it does, and the indications, so that I can open this discussion to you people in the audience so that you can ask your questions and I can be able to answer from there. Thank you.
Right. Thank you so much, Daktari. I wanted to also mention that for the members, you can utilize the chat function if you have any question. It doesn't have to be, related to today's topic. So you can shoot any question. So Daktari, I've seen a question in the past regarding insulin, and I just remembered. Of course, let me use an example of Mixtard. It comes in a vial, and of course there are Mixtard pens. So can I get myself from a vial to a Mixtard pen without involving my doctor? And what do I need to do?
Yes. Now, insulin, if it is the same type being sold as a vial or as a pen, is just the same. Okay, so you'll find Mixtard 30 in a vial. You can also find Mixtard in a flex pen, and it's in the same ratio. The whole idea is if it is a mixture insulin, it should be the same ratio. So the common insulin we have is Mixtard 30, okay? But we also have a mixture of 50 and I think a mixture of 75. Humalog mix, I think they have a 25 and a 50 and I think a 75. So long as it sticks to the ratio, then it's the same. The whole thing why we are trying to move away from vials to this other, from vials to pens, is for the convenience. You can imagine you have to travel with a vial together with a syringe, which is separate, and even in storage, it becomes an issue. That is what we were just trying to avoid. But it's true, so long as the mixture of the insulin remains the same. So let me try and answer some of these questions. Is triceber insulin available in Kenya? Now, triceber is an, how do I put it? Ultra long acting insulin. So we are developing insulins, especially the long acting insulins, which will work even for longer. So triceber actually works for around 48 hours, okay? And they're actually developing others which work for 1 week. So there are new insulins which are coming into the market, but they have not registered triceber in the Kenyan market yet. So it's coming. But I understand there are people who have it and they don't know where they're getting it. I'll not ask. So is the insulin pump available in Kenya? What would be cost? Yes, there is one diabetologist in Kenya who manages and puts patients on insulin pumps. It's called Dr. Gaman. Whoever that is asking, just know that insulin pump is not for everyone. It has indications. So, but if you're interested, kindly let Motanya know so that I can share the number with you. I wouldn't really know the cost, but I know it has a lot of consumables. The other question is, what do you do when a patient develops hypersensitivity to insulin, when the skin develops bumps? We try and change the type of insulin that we are giving you. It's as simple as that. So we always want to know which insulin were you receiving, and we try and give you insulins which most of the time are analog insulins, which are less sensitive to the skin, as you're talking about. Thank you, Daktari, for the session. Do we have any ongoing studies, e.g. stem cells, surgeries for repairing and regenerating damaged pancreas? Very good question. Yes, they're actually ongoing studies. I think they are in phase 2 right now. whereby a few patients were injected with stem cells so that they can divide into beta cells in the pancreas. And so far, so good, positive results, but we are waiting. Remember, for such a thing to be approved by the regulating bodies of the world, so the FDA and the EMA, it takes long. So even if it works right now, it might take another 10 years before it's actually allowed to be put into the mass market. So yes, it's actually an ongoing thing. The other question I'm seeing here is, can one deliver a child through normal delivery when they are diabetic? How long does the wound take to heal? Yes, actually, diabetic patients can deliver well, okay? It's just about how the diabetic patient has been managed, and they have to work hand in hand with the OBS guide. So this is a co-shared decision making. It's not one person to make that decision. We need to look at the weight of the baby. Remember, in mothers who are diabetic, what we fear is the baby becoming too big. And when the baby becomes too big, problems of deliveries become a problem, okay? And we try to avoid that by doing cesarean or elective surgeries. But yes, if we monitor you well enough, make sure that the sugars are within control and you're not having any of the complications, so preeclampsia, for example, and diabetes that is not uncontrolled, we might actually do a trial of labor on you. The other question is how to manage weight due to insulin. Well, I had expected this question. It depends, especially on the type of insulin that you're giving. There are insulins which are associated with more weight gain than others. But remember, when we are treating patients with diabetes, it's not just about the drugs. We have what we call lifestyle management and medical nutrition therapy. If you sit down with your nutritionist and the person who advises you, that is the educator, on how to live your life fully with exercise and eating well, you will actually get to manage this weight very well, okay? So it's not just about the insulin, it's also about the other aspects of your life that come into place so that we can always know that as much as we are giving you insulin, you're eating right and you're also exercising so that you do not gain weight that is antagonistic to what we want you as a diabetic to experience, that is weight gain. In some instances, there are drugs we give to manage the weight. But that is a topic for another day. So the other question I've been asked is, how does sensitivity feel like? So sensitivity comes in many ways. So one of the common things is you might have a skin reaction. That is a common one. The other thing is you might be injecting the insulin and it's not working the way you want. So what we call insulin resistance. So you have increased resistance to that kind of insulin. But the common one is actually a skin reaction, okay? The other one is, the question I'm seeing here is, what informs the insulin amount to be administered on a patient? Very true. One is the type of diabetes and your weight. The type of diabetes, we calculate it with a different ratio as compared to a patient who we are just augmenting. So when it comes to insulin, let me share two terms. Augmenting, which is we are giving you extra insulin on top of what you have. So most of the time that is type 2 diabetes. Replacement, we are giving you because you do not have any insulin at all. So we use a different ratio for that. So, and that ratio is also based on your weight. So you'll see a doctor asking you what is your weight, then they calculate, then they give you the amount of insulin that you need. Now, any new methods of testing blood sugar other than that, the prick? Yes, they are there. We have what we call GCM, glucose continuous monitoring. I think they are actually around in our market in Kenya right now. We have one from Libra and we have one from Medtronics. I can't really recall the name. But essentially, it's put on your arm, okay? Then there are some which come with an alarm. There are those that don't come with an alarm, so that if your sugar goes too low, it can actually notify your phone and you can know when your sugar is going. Now, remember, GCM is not for everyone, just like the insulin pump. It is for those patients who have very highly variable sugar. So they have hypos, then it goes to hyper. So it's good for those who we can't really put them in control. I noticed that my stomach has become swollen because of injecting insulin. What should be the solution to this? So remember, if you are injecting insulin not in the right way, you'll cause what we call lipodystrophy. So the fat around where you're injecting starts becoming hard. Such a patient should actually go to the hospital and be evaluated so that we see what we need to do. The other question is, please expound on insulin for kidneys impaired diabetic patients. So Anthony, what happens is this. The kidney is concerned with the removal of waste products from the body in a normal person and even in a diabetic patient. But because diabetes gives complications, and one of them is that it injures the kidney starts having problem excreting all these metabolites, all this urea and everything from your body to the outside. Now, if, for example, you are on oral medications, then they can't be removed from your body safely. So we actually changed you from oral medication to insulin. And even insulin itself as a drug is actually excreted from the kidney, okay? So you'll find kidney patients really need very little insulin to sustain them because that insulin actually keeps circulating in the circulation in the body without easily getting out. So yes, we use insulin and there are some oral medications which, as we speak, can now be safely used in people who are diabetic and have kidney issues because they are eliminated in other ways apart from passing through the kidney. So for example, the liver. So you'll find there are some patients who've been put in linagliptin, there are patients who've been put in empagliflozin or dapagliflozin or canagliflozin. Those are some of the drugs that we are seeing we can even use at kidneys which have been injured in such a way that they can help to actually slow down the kidney injury or make it better. The other question is from Prof. Chacha. Hello, I was diagnosed with type 1, but later after using insulin for 2 years, my doctor stopped me from using insulin. Then he put me on Trivimet tablets. Now the type 1, I can only survive on insulin. Is there harm to my body? Now, insulin is a hormone. So apart from just increasing weight and lowering your glucose sometimes to too low, it doesn't have any other issue. So it's actually a very safe drug. These are many questions. So I'll try and answer as much as I can. I'm using Humalog Quick Pen plain and Solo Star pens. I'm not adding weight at all. Thank you. I hope you can share with the rest of the people what you're doing so that they can understand that as much as you can add weight with insulin, there are other measures that you can do to actually not add weight with insulin. The other question here is, do you withhold insulin before surgery? Not really. We actually continue giving you insulin even when you are in surgery because your body continues to work. So what we withhold is some oral medications. The other question I'm seeing here is, let me try and move down. Just a moment. I think I've added everyone to the waiting room. Kindly, let me see. Let me see here. Kindly discuss the cost of pen insulin versus syringe. Yes, of course. I really don't know the cost themselves, but I know. pens are costlier than the vials, to another. But generally, the pens, because they are more convenient and because of their design, they are a bit more costlier than the insulins that come in vials. Hi, Dr. Good job. We'll visit soon. My question: Humulin 70 type 30 is what type of insulin? Very good question. Now, that is a Humalog mix 30. Okay, so Humalog mix 30. If you see 70-30, those are the ratios of the short-acting insulin versus the intermediate insulin. So we are giving you 30% of that insulin will cover your meal, and 70% of that insulin will cover the fasting period. So that is actually a mixture, insulin mixture. There's another question. I have seen in the internet a patch that is attached to your body and gives continuous reading there and up on your phone for 14 days. Is that locally available? Yes, it is locally available. It's called a GCM. I really can't tell you the cost unless you give me time to go and actually inquire how much it is. I think there are a few centers which are actually giving that. Dr. Gaman's clinic and I think Aga Khan, but I'll have to inquire. The other question is, sorry, I'm trying to, so that I don't jump any question. Thank you, Doc, for this. Does diabetic neuropathy affect the bladder in that it takes longer to feel the urge to pee? Yes. Neuropathy is one of those things Motanya will have, a discussion on its topic on its own. Because neuropathy is wide. It affects what we call the motor nerves. It affects what we call the sensory nerves. It affects what we call the autonomic nerves. So those are, yes, it can affect, you can have an automatic bladder. And remember, if it takes you longer for you to pee, you need to be assessed by the doctor before we just blame on diabetes as the only source. So there are some tests we will do for us to actually tell if it is something else or if it's the diabetes. Now, another question from Ngo Elenkong. Wow, such a nice name. What causes constant hypos, like at night and fasting blood sugar in the morning? I think I tried to explain this to a patient before. There are two phenomena, though they are medical, but I'll try and mention them. There is what we call a Sombody and a DONS. So in a normal patient or in a diabetic patient, all these things influence, there are things that influence how your sugar will read in the morning. One of those things is some hormones which are being secreted at around early morning. So we have hormones like cortisol and growth hormone, which causes resistance to insulin. So if they are impeding insulin to work, your glucose will rise in the morning, okay? Then we also have what we call the Sombody effect, whereby it now depends. What time was the insulin given? What dose of the insulin was being given? What food did you eat? So those things determine how your sugar will be. So for example, we might give you excess insulin at night. It causes your glucose to go too low, and your body, remember the thermostat? Your body reacts by producing glucose from the liver, and it returns the glucose past the thermostat level up. So you wake up in the morning and you find your sugar is too low, is too high. So how we always differentiate that, we'll tell you to measure your sugar at midnight and your sugar at 3 a.m. and we'll be able to tell you which is the issue and how we can manage it. iPhone to everyone. Hi, Dr. What is the progress in getting cure for type 1 diabetes? Well, pancreatic islet transplant is something that is in phase 2, I think, of the trial. It will take time, but don't hold on to your breath now because it takes time for such things to be approved. But for the people, the few patients who are being tried on, is showing some positive results. The other thing is pancreatic transplant, which is ordinarily not done on its own. It's done if when you are also needing a kidney transplant. And the reason for that is because when we give you an organ from someone else, we'll give you some drugs to trick your body to feeling that that organ is yours. And these drugs that we are giving you will also cause diabetes. So you see the issue. So we try to give it when two organs have failed so that we do them at the same time. But rarely do they happen, okay? I sleep at 10, 3 hours after my dinner with a reading of 5 or 6. On the morning, my first blood sugar is 2 digits. I don't know what 2 digits mean. What could be the cause? I've been pushed to check my cortisol levels, which are normal range. What could be the problem? So you are the patient I was saying, we need to measure your midnight and your 3 a.m. and we need to figure out what is causing. Is it a dose or is it a dose or is it a Sombody effect? So that one we can be able to figure out and give you. Most people need more insulin in the morning because of the resistance due to cortisol and growth hormone. Irene Ombui, I've taken insulin for 42 years. I've not had any side effects of those concerned with the long-term use. Please tell them insulin is a safe drug, okay? So you've seen someone who has used it for 42 years and they are still doing well. Can Novorapid be substituted with another insulin? Yes, it can. Remember, in a class of insulins, each insulin has a class. So in the Novorapid, we have glucin, we have, I keep forgetting, I have the market names. So we have Apidra, we have Humalog, and we have Novorapid, okay? And they can be substituted depending on which one works well with you. But most of the time we can interchange them and there is no issue. Would you recommend use of Jardiance in Vocana or Forxiga to kidney impaired diabetic patients, considering that they flush excess glucose through the urine? Anthony, that's a really good question. We are calling these drugs wonder drugs in the field of diabetes right now. And they are wonder drugs because one, as much as they flush glucose out of the kidneys, they are also what we call kidney protective. They are able to lower you from losing the proteins in your kidney, which is the early marker of kidney injury. And actually, they used to be used up to, let me use a layman's language, 30, which when you have a reserve of 30% of your kidney, and we can now even go to up to 20 and 15%. So these are wonder drugs. They have been shown to do really a lot in diabetic patients. And that is why if you get into any diabetes clinic, we want to measure your albumin-creatinine ratio to know if you are starting to lose the proteins, and we give you the drug. So they are even now being used in patients with heart failure. So they are really, really good drugs. But remember, it's your doctor to prescribe, not yourself. We have to do certain measurements to make sure that you actually need the drug or not. Why is it in surgical patients they commonly develop hypoglycemia related to hypermetabolic stress response? Why is it in surgical patients they commonly develop hyperglycemia related to hypermetabolic stress response? Now, surgery is a stress-related operation. Any stress that you put on your body, your sugar will go up, okay? So surgery is one of the conditions whereby there will be a lot of stress hormones being released. And because stress hormones mobilize glucose to handle the stress, you will always get a high sugar reading with any stress-related phenomena. So that is actually how I put it. Would insulin therapy restore some functions to a point one returns to drugs like metformin? It depends. If you're a type 1 or ladder, no. If you're a type 2, once we've normalized your glucose, remember glucose is also toxic to the cells that produce insulin. So once we reduce the toxicity around the beta cells, we can actually reinitiate metformin. Thank you very much for the talk. I would have been worried if I was to get insulin. Now you are informed. Please, Kibaya, insulin is not a bad drug. I try to educate patients. Insulin is not a bad drug. Insulin has just been mystified and people are associating insulin with bad outcomes. That's not the truth. Insulin, when used correctly, is a really good drug. It's actually the most efficacious drug of all the drugs we have in managing diabetes. Why is Humulin 70/30 not common in the Kenyan market? Well, I can't answer that. But what I know is the people who are marketing Humulin, which is Eli Lilly, left the Kenyan market. That is why it's becoming hard to actually get it. But I think they gave that function to a distributor, so I really don't know. So rapid acting insulins, thank you so much for correcting me. Aspart, glulisin, lispro, those are actually the molecular names. If diabetes has been triggered by long use of Zyprexa, which is olanzapine, can a patient reverse diabetes by going off the medication? It depends. It depends on so many things because we have to sit with this patient, assess the other risk factors that the patient has before we actually make that decision. Beatrice Kavai is asking, where am I? Where am I? I think I'm getting lost. Beatrice Kavai, do sulfonylureas react like other sulfurs, e.g. septrin, for people who are allergic to septrin? Well, I've not seen one myself. Actually, I've not seen one. So I wouldn't comment on that with conviction. So thank you. I think I've answered all the questions today. Motanya, back to you.
Thank you so much, Daktari. I was actually worried for you, kwamba utaongea sana. You need a glass of water maybe. So I think right now ni saa 2:55. Daktari, I can't thank you enough because of you know, creating time and coming here to talk to us. You know, really appreciate it, and I know all our members do. For the guys who are coming late, I wanted to mention and say that we'll be having these webinars hopefully every Thursday with Daktari. What our approach is easy. We'll pick a topic. Daktari will, as Daktari opens up, we will, you know, sort of like take some 10 to 15 minutes focusing on the topic, and later on we allow everyone to ask questions. So next week we're going to talk about how diabetes affects fertility in men and women and what can be done. And I wanted also to mention as we wind up that you can consult Daktari at DMMC Ngara every Saturday, 9 to around 1. Daktari is also found at Mpisha, so as any of you who would want to see him at Mpisha as well, you can make arrangements. So asante Daktari, and what I wanted to say is finally is appreciate also our members also creating time, coming and listening, asking questions. Asanteni sana. So Daktari, I think there are no questions, but of course a couple of comments from members. I guess appreciating. Thank you, Daktari, from Irene, Wanjiru, Baraka na Baraka. Thank you, Dan, Daktari, from Naji. And Anthony, and I know that we probably had so many other questions, but we also have another webinar next week. So asanteni and bye-bye.